Good morning to all. You are welcome to a new lecture series for psychiatric emergencies, and you are residents of emergency medicine. So we are here with the introduction of psychiatric emergencies. The overview of this session will be definitions and typical scenarios of acute behavioral emergencies, legal and ethical considerations in emergency medical response, importance of early recognition and intervention, practical strategies and safety in terms of initial assessment techniques of behavioral emergencies, use of restraint, sedative and legal considerations in psychiatric emergency, team communication strategies and personal safety measures. So the psychiatric emergencies principles are recognition of behaviors that pose risk to the health provider, patient or to the others or to the environment, assessment and management of basic principles of mental health system, suicidal risk. The mind and body are inseparable in terms of illness affects a person's behavior and physical illness can alter the patient's behavior, or the change in mental state can affect the physical health as well. So the two things are interrelated and to be looked upon in emergency unit. Condition that may pose a risk may be acute psychosis, agitated delirium, cognitive disorders, thought disorders, mood disorders, anxiety disorders, substance related disorders like substance intoxication and substance withdrawal, patterns of violence, abuse and neglect against child and adolescents and women and elderlies. The definitions are the definition of behavior is the way the people act or perform. The behavior may be overt or covert. The overt behavior is obvious and generally understood by those around the person by watching the gesture and action of the patient. Covert behavior is a hidden meaning and intentions which may be in the mind of the patient and may be intended to do harm to self, others and the environment. By definition, psychiatric emergency is behavior that threatens a person's health or safety and the health and safety of the another person. So the person's safety and other safety is important to be dealt with. And in another terms, a disturbance in thought, mood and or action which causes sudden distress to the individual or others and sudden disability or death, thus requiring immediate management is also psychiatric emergency. The cause of abnormal behavior may be biologic or organic, like organic brain syndromes, conditions that alter the functioning of brain, like delirious state. Environmental factors like psychosocial and sociocultural influences may also uh, cause the behavior to be harmful to others or to the self. Consistent exposure to the stressful event may also result into the harmful behavior of the person. Sociological factors affect the biology, behavior, and responses of the person. So all the environmental and psychosocial and cultural aspect can also influence the behavior in a dangerous manner. Injury and illness results in distress and impair coping mechanisms. The long-term illnesses like complicated diabetes, complicated hypertension or other condition may also lead to uh, behavioral changes. Acute trauma, uh, for example, acute stress reaction in lieu of some stressful situation which is acutely happened in the life of the person, which may result into the behavioral changes which is acute, and post-traumatic stress disorder, which is the late consequences of a traumatic situation. Substance related disorders like related to alcohol, illicit drugs and other substances may also be cause of the abnormal behavior. Now coming to the legal and ethical considerations in emergency medical services response, the act which we have is Mental Health Care Act 17, and it has various chapters talking about various aspects of caring of mentally ill people. And this is the brief and glimpse of the Health Care Act. The chapter 3 is regarding the advance directive, 4 for nominative representative, 5th for the right of the persons with mental illness, and 10th for the mental health establishment. In the detail, we will get to know about the mental health care in the detailed lecture. And this is the chapter 12, which is regarding the admission, treatment and discharge, and it particularly talks about the emergency treatment and the prohibited procedures, including restraints and seclusion. We will learn about this aspect in another detailed lecture. Now coming to the general principle of the psychiatric emergency management, is to ensure the scene safety. The first thing is save yourself when in doubt, and do not act alone when uh, there is high index of suspicion of violence or hostility. Relax the environment by removing stimuli, and search for a medical cause first behind the behavior, because many of the physical condition may lead to the behavioral disturbances. If the person found to be ill due to psychiatric illness, attempt verbal de-escalation and use the calm and firm voice to control the environment. Inform the patient aggressive behavior is not acceptable in a polite manner. Offer oral medications to help the patient return to the calm state, like benzodiazepine. Obtain consent when possible. Be clear in your explanations. Do not use the sentences or words which have abstract meaning or hidden meaning. The instructions should be clear and should be understandable by the patient. Situation with a strong behavioral component may have a sudden and unexpected turns of the event, so keep in the mind of the covert behavior of the patient. Patient assessment. The assessment of patient with a behavioral emergency differs from the other method, in which the healthcare professional is the diagnostic instrument. After ruling out the organic causes or physical causes, the mental state examination and your observation will be the key diagnostic tool to diagnose the condition. The assessment is the part of the treatment also. While you are doing assessment, you are also calming down the patient or pacifying the patient as well. Mental status examination is important in assessment, and use coast map. We will discuss coast map after in the slides. Examine the skin temperature and moisture to rule out any organicity due to autonomic hyper activity. Inspect the head and pupils for other organic reasons. Note unusual odors on the breath for substance intoxication. Examine the extremities and check for needle tracks, tremors, unilateral weakness, or loss of sensation uh, to rule out the substance use, the intravenous substance use, and tremors for withdrawal and other neurological conditions, and unilateral weakness and loss of sensation for the obvious CNS involvement. During the assessment, clearly identify yourself, your name, your designation, and for what you are there. And identification is also helps in giving authority, somewhat authority in front of the patient, and patient may found respectful towards the identity and maybe calm down. And for a general impression, assess appearance, posture, and people of the patient. Limit the number of people around the patient, so crowd should not be there, but sufficient number of staff should be there to protect in case of violent and hostile behavior and harm to self. Stay alert to potential danger and keep in mind the covert behavior of the patient. Airway, breathing, and circulation. Being a resident of emergency medicine, you already know what to do to establish airway, breathing, and circulation. So this is the coast map, mnemonic for the mental state examination. C is for consciousness. Check the level of consciousness and concentration of the patient. Orientation to time, place, and person to rule out the delirious-like condition. Activity, check for the activity, behavior, movement of the patient, the rate, volume, flow, articulation, and intonation of the speech. If this is if there is any irrelevant or incoherent speech, or maybe there are flight of ideas. Check for the thought. Is the patient making sense? Whether the patient is conscious or seems to be unconscious because of the sense of the thought. Memory, check for the recent, remote, and immediate memory. Affect and mood, do the inner feelings seem to be appropriate? Affect should be appropriate as per the the psyche of the patient and the environment of the patient, whether they are matching or not, and perception, whether hallucinations or other perceptual abnormalities are present or not. And particularly in the case of command hallucinations, patient may become hostile due to the hallucination giving command to the patient to harm to others or may harm to the environment. So be cautious regarding the perception of the patient. Communication techniques begin with the open-ended questions so you can get the clear answer uh, what you want to know, and do not use the question which has yes or no or leading questions. Let the patient talk enough so one can have idea what is going in the mind of the patient. Listen and show that you are listening and you are an active listener, so the person can come out easily with their feelings. And use of how and what questions should be more to communicate and to find out the psychopathology. Adjust approach the as and when needed during the communication techniques. Do not be afraid of the silences. Silences are the part of the mental state examination, and every moment shouldn't be filled with the words, and silence is also a kind of finding. Acknowledge the label feelings and do not argue with the patient. The argument may escalate the agitated feeling in the patient, and patient may become more violent or hostile. Crisis intervention skills. In crisis intervention skills, be calm and direct towards the person. Exclude disruptive people and sit down preferably at the 45-degree angle. Stay with the patient at all times. Bring all the medications. Never assume that it is impossible to talk with any patient until you have tried. In case of crisis intervention, maintain a non-judgmental attitude. Do not impose your own belief, ideas, and thought onto the patient. Provide honest reassurance. Develop a plan of action. Once the plan is set, allow the patient to exercise some control. So, so in the last, what is next in the row? Next in the row in the series of lecture, you will have lectures on violent and homicidal patients in emergency resulting from substance intoxication in detail, substance withdrawal in detail, psychiatric aspect of domestic violence, elderly and child abuse and rape, suicide and parasuicidal behavior, delirium and organic mental disorder, depressive stupor and catatonia, fatal side effects of psychotropics and management, lithium toxicity. Lithium is used for mood stabilizer in case of bipolar disorder, so it can lead to toxicity. We will talk about that. Approach to the panic attacks in the emergency, and Mental Health Care Act 2017 and related to emergency conditions. So thank for the patient listening, and wait for the details lectures to be taken by the various faculties. Thank you.